Hello everyone and welcome. I am Professor D and I have a master's in nursing and currently teach full-time. I know exactly what you need to get through nursing school and pass ATI, the HESI, and the NCLEX. Stick with me and we will get you through nursing school. You will no longer have to figure out what you need on your exams because I know what you need. Alright, today we're going to dive into a high-yield nursing topic called heart failure. Let's get started. Heart failure is a clinical syndrome where the heart cannot pump enough blood to meet the body's needs. It doesn't mean that the heart has stopped working entirely, but it is struggling to circulate blood effectively. This decreases oxygenation and perfusion to your kidneys. Heart failure can be due to a weakened muscle of the heart, hypertrophic cardiomyopathy or oversized heart muscles. Also, the chambers of the heart can become damaged due to a heart attack, or faulty valves from age-related issues or infectious agents. Heart failure affects millions worldwide and is one of the leading causes of hospitalization in older adults. To understand heart failure, we need to start with the basics of how the heart functions. The heart has 4 chambers, 2 atrium on the top and 2 ventricles on the bottom. Blood flows in from the body into the right atrium, then moves to the right ventricle, which pumps it to the lungs. Once oxygenated, the blood returns to the left atrium, flows into the left ventricle, and then is pumped out to the rest of the body. It's a beautifully synchronized pump. But what happens when the pump weakens and cannot pump effectively? That's heart failure. There are 2 major categories of heart failure, systolic and diastolic. Systolic heart failure, also known as heart failure with the reduced ejection fraction, or HFrEF, occurs when the heart muscle is too weak to contract effectively. Ejection fraction, normally between 55 to 70%, drops below 40% in systolic failure. On the other hand, diastolic heart failure, or HFpEF, occurs when the heart muscle becomes stiff and cannot relax properly. This limits how much blood the ventricle can fill with, even if the ejection fraction appears normal. We also classify heart failure based on which side of the heart is affected. Left-sided heart failure is the most common, and it often leads to right-sided heart failure if not managed. In left-sided failure, blood backs up into the lungs, leading to symptoms like dyspnea, orthopnea, crackles on auscultation, and fatigue. Right-sided heart failure causes blood to back up into the systemic circulation, leading to peripheral edema, jugular vein distension, hepatomegaly, which is known as an enlarged liver, and weight gain. Remember, we are always concerned about a weight gain of 2 pounds or more in a 24-hour period, because you cannot gain or lose a pound of fat or muscle in 24 hours. So that must mean we are starting to retain fluid since our kidneys are not perfusing effectively. Now, let's talk about the signs and symptoms. Common complaints from patients include shortness of breath during activity or when lying flat, fatigue, weakness, swelling in the legs and ankles, sudden weight gain, and a persistent cough. Sometimes this cough has frothy, pink sputum involved. Patients may also experience rapid or irregular heartbeats. One key assessment finding in the hospital is the presence of crackles in the lungs upon auscultation and jugular vein distension. From a diagnostic standpoint, we use several tools. A chest X-ray can show an enlarged heart or fluid in the lungs, called pleural effusions. An ultrasound can show blood flow, and an echocardiogram gives us a direct look at the heart's pumping ability, and it is how we measure ejection fraction. Blood tests, particularly BNP or B-type natriuretic peptide, are also helpful. Elevated BNP levels indicate that the heart is under stress by being stretched and trying to compensate for volume overload. Managing heart failure requires a multi-pronged approach. Pharmacological treatment is foundational. ACE inhibitors help relax blood vessels and reduce the workload on the heart, and the patient can also become hypotensive while taking this medication. Beta blockers slow the heart and reduce oxygen demand. Diuretics like furosemide, a loop diuretic, help the body get rid of excess fluid. Other medications may include aldosterone antagonists or digoxin to increase the contractility of the heart, depending on the severity and the response. Don't forget about checking the apical pulse for 1 full minute with digoxin and be concerned about digoxin toxicity. But medication is not enough. Patient education is absolutely critical. Patients need to understand how to monitor their weight daily, and we would do that in the hospital as well. Any sudden increase in weight may indicate fluid retention. We recommend weighing every morning at the same time with the same type of clothes and on the same scale. Remember, a gain of 2 or 3 pounds overnight or 5 pounds in a week should prompt the patient to call their provider. Sodium restriction is also very important. No more than 2 grams per day. Fluid restriction may also be recommended in more severe cases. Patients should also be encouraged to elevate their legs, limit alcohol intake, and avoid smoking. They need to maintain an exercise routine to remain physically active and consult with the provider before starting any exercise regimen. And perhaps most importantly, they need to adhere to their medications and follow-up appointments. Now, let's not forget about NCLEX, HESI, and ATI tips. A patient who develops a dry cough while on ACE inhibitor may need to switch medication and notify their provider. When giving diuretics like furosemide, always monitor potassium levels, as hypokalemia, which is less than 3.5 millimoles per liter, is a serious side effect. They will need potassium supplements if they are low. Remember, we never give straight potassium IV, as this will kill a patient. Potassium IV needs to be mixed in saline. Remember to educate your patients about when to report symptoms like new swelling, increased fatigue, or changes in breathing. It is vital for early intervention. In severe or advanced cases, patients may need implantable devices like an ICD or a biventricular pacemaker. Ventricular assist device or inotropic medications, and these inotropic medications may lead to chest pain or even a myocardial infarction because they put more stress on the heart. In some cases, a heart transplant may be the only option, but with proper management, many patients live full and active lives, even with heart failure. Older adults have an increased risk for heart failure and can have worse manifestations due to increased systolic blood pressure due to some medications. Here are some of the risk factors for left-sided heart failure. They are hypertension, coronary artery disease, angina, myocardial infarction, and mitral and aortic valvular disease. Risk factors for right-sided heart failure is left-sided heart failure, right ventricular myocardial infarction, and pulmonary problems such as COPD and pulmonary fibrosis. Risk factors for high output heart failure is the increased metabolic needs of the body, septicemia, anemia, and hyperthyroidism. Cardiomyopathy leading to heart failure can be caused by coronary artery disease, infection or inflammation of the heart muscle, various cancer treatments, prolonged alcohol use, and hereditary issues. Expected findings of left-sided heart failure would be dyspnea, orthopnea, which is shortness of breath while lying down, nocturnal dyspnea, fatigue, a displaced apical pulse due to hypertrophy, S3 heart sound, which is the gallop, pulmonary congestion, which would be dyspnea, cough with bibasilar crackles, frothy sputum, may be blood tinged, altered mental status, manifestations of organ failure such as oliguria or a decrease in the urine output, and nocturia. Expected findings of right-sided heart failure are jugular vein distension, ascending dependent edema in the legs, ankles, and sacrum, abdominal distension, ascites, fatigue, weakness, nausea and anorexia, polyuria at rest, especially nocturnal, liver enlargement or hepatomegaly, tenderness, and weight gain. Now let's talk a little bit about cardiomyopathy leading to heart failure. Blood circulation to the lungs is impaired when the cardiac pump is compromised, and there are 4 types of cardiomyopathy. There's dilated cardiomyopathy, which is the most common, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and restrictive cardiomyopathy. The manifestations of these are fatigue, weakness, left-sided heart failure, dysrhythmias or heart block, S3 gallop, cardiomyopathy or enlarged heart, which is more severe with the dilated type of cardiomyopathy, and then of course angina. For hemodynamic monitoring, we need to remember that heart failure generally results in increased central venous pressure, increased pulmonary wedge pressure, increased pulmonary artery pressure, and decreased cardiac output. To wrap up, heart failure is a condition where the heart cannot meet the body's demands. It can be diastolic or systolic, left or right-sided, and it presents with fluid overload symptoms, and we diagnose it with imaging and labs. We treat it with medications, lifestyle changes, and patient education. And of course, as nurses, our job is to recognize, intervene, and educate. Our care would include monitoring daily weights and intake and output, assessing for shortness of breath and dyspnea on exertion, administering oxygen as prescribed, monitoring vital signs and hemodynamic pressures, positioning the client to maximize ventilation such as high Fowler's, monitor the diagnostic results to track progress, assess for manifestations of medication toxicity such as that in digoxin, encourage bed rest until the client is stable, encourage energy conservation by assisting with care and activities of daily living, maintaining dietary restriction as prescribed, such as restricted fluid intake and restricted sodium intake, provide emotional support to the client and family. Thank you for learning with me today. I'm Professor D. And remember, keep your hearts and your patients healthy. You got this.